Hello, this module will evaluate the utility of pulmonary ultrasound with a particular focus on how point-of-care ultrasound can be useful to look at the lung parenchyma. Fundamentally, the idea of using ultrasound to identify the lung parenchyma has often up until recently thought as a misnomer because of the fact that one would identify that interface of the lung tissue, allowing too much ultrasound reflection and therefore preventing penetration into the lung tissue. And for the longest time, therefore, the utility of pulmonary ultrasound to identify actual lung parenchymal disease was not thought of. However, what we've been able to demonstrate over time, many specialties have at least demonstrated, is that actually taking advantage of this concept. So meaning that when the lung tissue is no longer uniform in its aeration, that produces distinct artifacts or distinct ultrasound signals or signatures that allow us to identify pathology. And sort of the frequency of these signals or artifact signatures allows us to quantify the degree of one's airspace disease. Fundamentally, what we're looking at is how one's air content is uniform or not in the lung parenchyma. And the more lack of uniform nature of aeration to the lung tissue results in more artifact signatures. So thus, the more the air content decreases in the lung fields that are getting insulated by the ultrasound image will allow more signatures of artifact that we can detect. These signatures of artifact are called B lines. And we'll talk about this more on the next cartoon picture on the next slide. But the fundamental concept of B lines is a marker of differentiation and aeration of tissues in that ultrasound plane. And the more B lines you see, the more areas of differentiation of aeration or the poor aeration of uniformity in that lung image window. So the concept of B lines are that when you have differentiation in lung density, you present what ends up being a vertical hyperechoic image arising from the pleural line, extending throughout the ultrasound image that moves synchronously with respiration. These B lines are secondary to, again, the differentiation in the air content or density in the tissue planes. Let me try to show you a cartoon here to identify this a little bit clearer. If we have this ultrasound image showing penetrating in this picture here, you would see that in fact the ultrasound window is going through areas of different aeration as the ultrasound waves penetrate. When it intonates between an area of less aeration versus an area of more aeration, that will present a area of reverberation or a difference in tissue density that produces these vertical lines called B lines. These B lines, again, are an indication of differentiation in aeration of the lung tissue. And the more vertical lines you have from the lung pleura, extending throughout the ultrasound image, the more degree of differentiation of aeration you have in your lung window. So again, we're looking for these vertical lines. More than 2 is a sonographic sign of lung interstitial disease, and the more numbers we see, it results in worsening in airspace pathology. As this gets even further, you can actually see complete consolidation of lung tissues in the acoustic windows of the lung ultrasound exam. And the identification of these more echogenetic collapsed lung organ areas is pathognomonic for the identification of consolidation. One actually has been able to, studies have actually been used to evaluate the measurement of the space between these B lines as to provide further detail of the pathology of airspace disease. So when one has multiple B lines that are less than 7 millimeters apart, this is likely to represent interstitial edema versus B lines that are 3 millimeters or less apart. That is most likely caused by alveolar edema. So the less space you have between the B lines indicates more alveolar edema versus the more space indicates more interstitial pathology. But fundamentally, when it comes to the concept of lung parenchyma evaluation, what we're looking for is the number of bead lines and the degree of this throughout the lung field. So we calculate the number and the intensity of bead lines because those two increase as the degree of aeration gets worse. So again, let's fundamentally talk about this again. A bead line is a representation of differentiation in the tissue density secondary to areas of normal aeration next to areas of poor aeration. The more that representation between the area of aeration to poor aeration produces these reverberation artifacts signals called bead lines. The fundamental concept of a bead line is a long vertical line extending from the lung pleura throughout the ultrasound image and should extend throughout the lung parenchyma at least to the depth of 10 centimeters. Quantifying the number of bead lines can represent the areas in which you have this differentiation in aeration. So therefore, the more bead lines you have, the more areas of differentiation in aeration you have, meaning the more areas of poor aeration versus normal aeration you have in that ultrasound window. So counting the number of bead lines relates to the severity of the patient's airspace disease. You can in fact actually march these out. So this cartoon here is demonstrating that as the ultrasound image is shown above, you go from one bead line to two bead lines to many. The aeration is getting worse as you go from left to right. You can actually quantify this further and evaluate the improvement or worsening of one's condition based on the presence of these bead lines. It's important to realize that we are looking for lung parenchymal artifact generation from these poor aerations, which is the definition of a bead line. However, there are other lung ultrasound artifacts that need to be addressed to make sure that they are not falsely counted as bead lines. One is the concept of A lines, which A lines are horizontal compared to the vertical lines of the B lines. A lines are horizontal and are actually reverberation artifact of the lung pleura itself. Z lines are short vertical comet tails that rise from the pleural line but do not extend more than 2 to 3 centimeters. And they definitely do not extend to the distal edge of the screen. So this is why we need to have a depth of at least 10 centimeters to show that we're actually looking at a representation of the lung parenchyma. Z lines in fact represent just a pure differentiation in the tissue density of the pleural line itself. How do we do the examination? Well, it's very similar to how we evaluate for pneumothorax using the high-frequency linear probe, except now we're using a lower frequency probe to allow the ultrasound wavelengths to penetrate into the lung parenchyma. So either the phased array or curvilinear probe, either one of these probes will allow us to penetrate the ultrasound image into the lung parenchyma and be able to get an accurate ultrasound examination. Either way, the indicator should be just as you would for the pneumothorax evaluation, with the indicator aiming at the 12 o'clock position and going through the anterior fields as identified as we discussed for the pneumothorax, starting off at the study. So starting off the mid-clavicular line at the proximal 1/3 of the chest wall and moving lateral to the anterior axillary line on the distal aspect of the chest wall. Always keeping the probe in between the rib spaces to ensure that we have a vertical ultrasound plane cross-section of the lung parenchyma. And again, fundamentally what we're looking for is worsening and more presentation of these vertical lines, and again that represents worsening of the patient's airspace disease to the point where we ultimately have consolidation of lung parenchyma, which would indicate again essentially no aeration to this area. There are many protocols when it comes to lung ultrasound, and this is actually a very complex topic. This goal of this module is simply to provide a very basic overview of the concept of bead lines, again, which is the idea of a marker of poor aeration or differentiation and aeration of the lung parenchyma. And the more vertical lines you have, extending throughout the ultrasound image beyond 10 centimeters, which again is what a B line is, the worsening the patient's status is regarding their pulmonary aeration. But again, there's many protocols that discuss this topic in much greater detail. The Blue protocol has been developed to help diagnose patients with acute respiratory failure. Additionally, the Falls protocol has also been used and discussed as a lung sonography technique for the management of patients with acute circulatory failure as well. So I encourage you to evaluate these different protocols, learn more about the topic, and hopefully use this as a starting point to get you involved into the concept of using point-of-care ultrasound to evaluate the aeration of the lung parenchyma. Okay, so now we're going to go into the section of pulmonary ultrasound to evaluate for airspace disease. So the examination is actually the same exact probe placement that you do for examination of the lung pleura to evaluate for pneumothoraces, but now essentially we're using the lower frequency probe to allow for deeper penetration, and you're going to adjust your depth on your ultrasound machine to be able to incidate at least 10 centimeters into the lung parenchyma. And what we're going to look at, so here we've identified, we'll put it at 12 centimeters here. We're going to place the ultrasound probe exactly how we do for the evaluation for pneumothoraces, or looking at the lung pleura, which again means starting at the mid-clavicular line for the proximal 1/3 of the chest wall, and then moving laterally up to the anterior axillary line as we are at the inferior border of the chest wall. So indicator again will be at the 12 o'clock position, starting here. And what we're trying to identify here when it comes to the evaluation of the lung parenchyma is the concept of B lines, or these bands, vertical lines that extend throughout the image shown here, indicating again the differentiation in tissue density that correlates to airspace disease. And we quantify the number of B lines that we see, and so here you see quite a bit of shimmering of these B lines. We'll go over to the other side here to mimic that, and by showing diffuse B lines throughout lung fields on both sides, that gives an indication of what the mechanism of pathology is for that, versus having B lines only on one given lung segment. The identification of B lines in only one given lung segment potentially correlates more with the potential of pneumonia versus processes that would involve the entire lung, such as fluid overload, or somebody who's going into diffuse airspace disease, would affect both sides of the lung equally. But this is again the concept of evaluating the lung parenchyma for airspace disease. You follow the examination exactly how you do for the lung pleura, following again from the mid-clavicular line, working your way laterally to evaluate the entire anterior aspects of the lung fields. And I ask you to kindly look at the PowerPoint images to evaluate the full examination.